Good morning, everybody. Well, it's great to be here in person. This is also my first in-person meeting after 2.5 years, so it's wonderful to see everybody. I'd like to start off by thanking the National Academies and the Planning Committee for this opportunity to moderate this session. It's my pleasure to introduce Maggie Little, the keynote speaker. Maggie is a senior research scholar at the Kennedy Institute of Ethics and professor of philosophy at Georgetown. Her research interests include issues in reproduction, clinical research ethics, data ethics, and the structure of moral theory. She was appointed to the Ethics Committee of the American College of Obstetrics and Gynecology, and she is co-founder of the Second Wave Initiative, which works to promote responsible research into the health needs of pregnant women.
Yes. Hi, everyone. I'm sorry I can't join you in person, but delighted to be here with this amazing group of people and this important convening by the National Academies.
All right. Yes, sorry you couldn't be here in person, Maggie, but we're glad that you could join virtually. Okay, so I'm going to get us started off. So there's still general misunderstanding and misinformation among the general public and among some stakeholders about the appropriateness of including pregnant and lactating individuals in clinical trials. There are interesting ways that ethicists approach the issue of including pregnant and lactating individuals in clinical trials based on various fundamental ethical principles that really make a compelling argument for the inclusion of pregnant and lactating individuals in clinical trials. Could you break it down for the audience and talk about these ethical principles and how they apply to the inclusion of pregnant and lactating individuals in clinical trials?
Yeah, so as Ruth and Shirley already beautifully articulated, the issue that we're addressing is an inequitable evidence base for pregnant lactating individuals. And so already that wears its sort of ethical challenges and problematic nature on its face, if only in a sort of utilitarian sense that when we don't attend to this population, we're going to have problems. But what's interesting, and what we've argued in various of these guidances, which have worked on the phases and the prevent, and been involved with Ruth and many others on this issue for a couple of decades now, is that inequitable evidence base also violates the specific moral principles that animate the very premise of clinical research as an enterprise. So let me mention the three really important sort of tenets of clinical research that inequitable evidence base contravenes. So the first is probably the most obvious, that clinical research enterprise is meant to express a commitment to protecting the safety of those who use drugs by first assessing them under the carefully controlled and regulated conditions of a clinical research trial, instead of just releasing it into the wild to be used clinically without that evidence gathered carefully. When you make an exception of pregnant women, pregnant people and lactating people in that clinical research enterprise, in part often because of a fear that we somehow shouldn't be exposing them to drugs under the context of research, you're actually just exporting that risk into the clinical setting. As Shirley said, 70% of pregnant people use prescription medications, right? And so you're actually exporting the risk, not getting rid of it, and expanding it because now millions of people are using it. Second issue is perhaps less obvious to folks outside this group who haven't attended to the specific granular issues that pregnant lactating people face. And that's the reticence of providers to prescribe or national guidelines to endorse the use of next generation drugs in this population without an evidence base or equitable evidence base. So a little bit unlike some other special subpopulations who also sometimes lag in getting a robust evidence base, we have a sort of maybe understandable but probably wrought cultural anxiety about what we don't know about the fetus can make us think we have to default to not giving any drugs, when in fact, they're not paying attention to the risk of the underlying disease or risk of acquiring that disease is its own risk that you're actually incurring. And so there's massive evidence that the lack of evidence base for pregnant lactating people drives a huge reticence to give them access to the life-saving medications that are coming on board. So COVID vaccines, we've seen it in malaria, where pregnant women have long been prescribed only the old-fashioned anti-malarials, when malaria is a huge killer of pregnant women across the globe because the fluke sequesters in the placenta, okay? So the lack of evidence base critically impedes equitable access of pregnant women and lactating women to the medicines that they and their children need. And the third one is really an issue about equitable respect for pregnant lactating people. So when research is conducted with that population, as it is sometimes, right, just not enough, often the outcomes that are tracked in the research are limited to fetal outcomes, as opposed to also tracking, since you've got her enrolled, outcomes specific to her health. And that, we've argued, and many would agree as an ethical principle, is disrespectful to her independent interests. So pregnant lactating people are not just vessels of the fetus or of the newborn child. They retain their own autonomous interests, and those can't and shouldn't be oblated in the research context.
Great, thanks, Maggie. Okay, so we'll go on to the next question that I have for you. You've been working a long time in this area, and it seems to me like we have come a long way, at least in terms of understanding each other's perspective and making some progress in advancing the inclusion of pregnant and lactating individuals in clinical trials. It seems like the question used to be, should we include pregnant and lactating individuals in clinical trials? To more recently, in the last several years, how do we include pregnant and lactating individuals in clinical trials? Could you talk about this evolution and the conceptual shifts that have occurred?
Yeah, and it is an important and exciting momentum toward that, as Ruth and Shirley mentioned at the beginning. So the conceptual shifts that have helped that move, there are three that probably deserve special note. One is a conceptual shift from construing or categorizing pregnant and lactating people as a vulnerable population for clinical research purposes, into seeing them as a morally and scientifically complex population. So that first construal of viewing this a vulnerable population was really problematic and consequential, producing a chilling effect on thinking the very idea of doing research with that population was somehow morally impermissible or anathema. And that's because vulnerable as a category in the regs, okay, was meant to describe a population that had a compromised ability to give valid consent to research. So amongst the other populations that were described in that way were children, those with dementia, those in prison, right, who don't have sort of enough voluntariness to count as giving valid consent. And so when a population is considered as vulnerable, there really is a press to say, do anything except do research. It's the last resort, okay? That's problematic as it applies to the population of pregnant lactating people. There's nothing about those conditions that undermines the ability to think clearly and make valid decisions. There's nothing common to that whole population. So individual pregnant and lactating people might be vulnerable, but the population as such isn't. So in very important progress, major guidances and professional organizations, including the American College of Obstetrics and Gynecology, now say not a vulnerable in the technical sense population, but a complex one, okay, that deserves special protections, special stipulations in the regs, but not something, not a population that shouldn't be researched. And very happily, recently, and I'm thinking it's 2018, the common rule of the regs remove pregnant women as a vulnerable population for just these reasons. So, yay. Second one is a kind of conceptual shift that actually this conversation on pregnant lactating learned from the amazing efforts 30 years ago to try to do better on clinical research with the pediatric population. So they did a beautiful conceptual shift that this movement now has borrowed of moving from thinking of protecting from research to protecting through research. And that refers back to the principles I was mentioning before, that without gathering evidence in the importantly controlled context of clinical research, you're actually putting that population's members at greater risk. And the third and super important one that is gaining traction is a conceptual shift from presumed exclusion of pregnant lactating people in trials to a concept of fair inclusion. Let me just say a couple words about this last conceptual shift. The presumed exclusion has been not only, has centrally been a sort of default that is not based in moral principles, but an artifact of those conceptualizations I mentioned about vulnerable, the worry about the thalidomide crisis that was mentioned, and also the fact that unusually large funders don't ask for any justification to exclude pregnant women, but they do ask for justification to include them. So it's just easier to exclude them presumptively. Less paperwork, if nothing else. Okay. To thinking of it as fair inclusion, where very importantly, fair inclusion is meant to be a nuanced notion. It's not that you should presume that every trial should include pregnant lactating people. It's you should review the trial, and if pregnant lactating people are eligible for inclusion by reference to the regs, which so often they actually are, then you should need a very specific rational reason for excluding them.
Thanks so much, Maggie. Okay, so going on to the next question. You have made a significant contribution to advancing the inclusion of pregnant and lactating individuals in clinical trials, including your work in the phases and the Prevent HIV guidance and the call to action that was published in December 2021. Could you provide kind of an overview for the audience and discuss their importance?
Yeah, so the Phases project, which was specific to giving sort of roadmap for improving the evidence base in the context of HIV and its comorbidities. And then others will speak to the Prevent guidance, which did similar but groundbreaking work in a pathway to improving it in the context of vaccines and epidemics. But Phases intentionally took the context of HIV as a disease to look at a very granular level to give guidance to, because the HIV research community has actually been a vanguard at being willing to do any research with pregnant women in order to try to decrease vertical transmission from mother to child. And so because of that vertical transmission, it was much clearer to those in the research community that we have to do some research with pregnant women. And so looking at that disease state and the people who've done important research, we could learn a lot about study designs that actually are really useful with pregnant and lactating women. And also, what are the barriers that keep the research still nonetheless keep the research from doing what it really ought to do, even in the context of a disease where everybody agrees that the underlying disease is very dangerous to the fetus. So convened a large working group, worked for many, many years, conducted an enormous number of individual conversations and consultations across countries and contexts and disciplines. Lots of representation of people living with HIV, as of course is crucial, and came up with recommendations I won't go through all the details, but they really ranged from things that are needed to build the capacity of researchers to do this kind of research, because it is technical. It requires, finding a liability company that is willing to cover your trial, and so giving specific guidance on that. Ideas for helping to incentivize inclusion by funders, or what IRBs can do to promote this, like saying, why aren't you including pregnant women? Really importantly, enhancing post-approval safety assessments. So not all safety assessments can be done in the context, as Layla very much knows, in the independent new drug context. Some of those safety assessments require huge numbers in order to find any potential elevated risk to the woman or the person or the fetus. And in part, let me just mention that's because, especially for fetal safety issues, which is the one that captures the public's imagination, the baseline rate of problems with for the newborn from pregnancy. For instance, the baseline rate of birth defects is 3%. That's just right. What pregnancy is like, higher in some lower resource settings. So to really figure out when a baby is born after exposure to a drug, was it attributable to the drug, or was it part of that 3% baseline? You need enormous numbers, and so we need better and more creative methods of gathering those post-approval data, as well as working harder in the IND context.
Thanks, Maggie. So we'll move on to the next question. You talked about the common role and removal of reference to pregnant individuals as a vulnerable population. Now, interestingly, the PregLac reports had some recommendations related to revising 45 CFR 46 subpart B, additional protections for pregnant women in research, which have been noted as presenting regulatory barriers to conducting clinical trials in pregnant and lactating individuals. And we've had discussions on these issues at various meetings. Could you share your thoughts on these PregLac recommendations?
A couple of thoughts. First of all, I think they're all fantastic. Many in the audience, myself included, testified in front of PregLac to say, here would be some really great tweaks. And I think the combined wisdom of that discussion with PregLac resulted in great recommendations. They include things like tweaking the minimal risk standard for trials that have no prospect of direct benefit, to dropping the requirement for secondary paternal consent. It's not required much in the regulations now, but getting rid of the one scenario that it is still. That said, two other comments, okay, that I think are important. The first is, I think it's very important, first of all, to give a shout out to Layla and her group. They've been working tirelessly to try to better what FDA is allowed to require. They probably lack the legislative authority currently to do. In my discussions, at least with many of them, they're supportive of those regulatory reforms. It's not like they themselves can unilaterally institute it because they're limited currently in legislative reform. So I just want to make clarification of that for our audience. FDA is a partner here in this effort. They're not the problem in my view. And the third thing I always want to emphasize when we start talking about regulatory reform, again, on all of these projects, we've really surveyed what the barriers are barriers to actually conducting this research. Why isn't it being done more? And regulatory barriers are not the big problem. The subpart B is actually pretty decent. It's pretty commonsensical. Is it perfect? No. Are any regulations written by committees perfect? No. The lion's share of problems are really things about culture and liability and challenges of capacity that are going to be discussed later today. And I say that not because the regulatory changes wouldn't be helpful, but I worry sometimes about people thinking it's all about needing to make those changes That's problematic for two reasons. I think there's second order problems instead of first order. And if they take legislative solution, we know how challenged Congress is to make any legislative solution. So I don't want that. We don't want that conversation to overshadow all the other things that could be done that would make a huge difference, even without Congress.
Okay, great. Thanks for those points, and thanks for the shout out. So we're, in the interest of time, I think we have around 2 minutes left. So I guess I'll skip my last question, and I'll leave the last 2 minutes for you to share any closing thoughts that you may have, Maggie.
Yeah, I will say, again, as somebody who's worked on this for not as long as Ruth Baden, who's an OG goddess on this topic, just shout out to Ruth. But as somebody who has been working on it for 20 years, I cannot tell you the change that I've witnessed between people who just can't even believe the questions being raised and have foundational confusions, think the regs prohibit this research, which is just a myth, right, was rampant then, to the change now of people, so many different professional organizations, presidential task force, national academies continuing to be a place that advocates for this. And as you said, Layla, so much work now being done on how to do this research. So what are the specific places inside the IND process we could do stuff? What are the specific things that would matter most in post-approval independent research that makes a difference? So we're starting to move just from manifesto to how to actually build the solution.
All right. Thank you so much, Maggie. I'm sure the entire audience really appreciates your thoughts. Thank you so much.
Thank you.
Would the panel like to come up, please? It's my pleasure to moderate the first panel session, and this is related to discussing what the current evidence gaps are. So I'd like to start off by introducing our panel members. Sarah Mancall is a mother and advocate. She has a chronic autoimmune condition that worsened during her pregnancy. And since then, she's become an advocate for research that includes pregnant and lactating persons. Outside of her personal advocacy work, Sarah is the policy director of a scientific association. Dr. Thomas Hale is the University Distinguished Professor of Pediatrics and Assistant Dean of Research at Texas Tech University School of Medicine. He's the founder and director of the Infant Risk Center, a national call center for pregnant and breastfeeding mothers. He's a world-known expert in clinical lactation studies and is the author of 5 books, including Medications and Mother's Milk, the top-selling drug reference manual that everybody uses frequently. He's authored numerous papers, case reports, and abstracts, and more than 30 book chapters. Dr. David Haas is a board-certified OB-GYN physician. He's the co-director and editor of the U.S. satellite of the Cochrane Collaboration Pregnancy and Childbirth Group and has served on World Health Organization guideline development groups. He runs a research team with expertise in recruitment to obstetric cohorts, biobanking, and clinical trials, and collaborates on several multi-center trials and has a passion for team interdisciplinary science. Ajoki Termulin is the Vice President, Medical Affairs and Policy at Icosavax. In her role, she leads the medical affairs strategy for Icosavax's vaccine programs. Prior to her current role, Ajoki led the Global Maternal Immunization Initiative with a focus on Group B Strep maternal vaccine development at the Bill and Melinda Gates Foundation, and prior to that at Novartis. I will now open it up and invite each panel member to provide some opening remarks. And I'd like to first start off with our patient representative, Sarah, as I think that the reason that we're all here, of course, is that we're all here for our patients. So I think that it's great that we have a patient representative. So I'll turn it over to you, Sarah. Thank you.
Thank you, and thank you for inviting me to provide a patient perspective. So I have alopecia areata. It's actually been in the news a bit lately with Jada Pinkett Smith, and I don't know if you all read the New York Times recently, but there's a brand new medication on the market that actually just was approved by the FDA, which is very exciting because it's really a breakthrough medication for alopecia patients like myself. I'm actually in a clinical trial, and I'll talk a bit about that in a minute or two. So the disease varies from person to person. Some people lose small circular patches of hair here and there. Other people lose all of their body hair. Prior to having children, I was thankfully able to keep my hair loss to a minimum by visiting my dermatologist monthly or bi-monthly and receiving corticosteroid injections at the affected sites of my scalp. These injections were painful and disruptive to my workday, but at least they kept my disease in check and spurred enough hair regrowth that I was able to hide my periodic bald patches. When you have a disease like alopecia areata, one for which there's no cure and there are no particularly effective medications on the market, at least as of 3 days ago, you can get pretty desperate to keep things from progressing. By the time I decided to start a family at the age of 30 years old, I had already been living with alopecia areata for 8 years. At the time, I visited each of my doctors, my OB-GYN, my dermatologist, and my primary care physician, to get guidance on how I should approach intralesional corticosteroids should I become pregnant. Each of my doctors did some background reading, and each of my doctors suggested that it was probably fine to continue receiving the corticosteroids since they were only being injected at the affected sites. Nevertheless, there was no clinical data to inform my doctors on the issue, and so none of them felt comfortable giving me real guidance. Without clinical data to inform my decision-making process in consultation with my doctors, I felt deeply frustrated. In the end, I decided to forego corticosteroid injections for the duration of my pregnancy and lactation period. 3 months after having my first child, 12 or so months after getting pregnant, all of my hair had fallen out. 5 years later, when I was done having children, I tried to pick back up with intralesional corticosteroids to regrow my hair. The treatment no longer worked for me. Today, I'm 40 years old. I'm done having kids, and I'm 2.5 years into a clinical trial as a research subject for a new medication that might someday be used to treat alopecia areata. It's a JAK inhibitor, but it's a different JAK inhibitor from the one that was just approved. I love that I can participate in research and help give back to the alopecia community and to the broader endeavor of scientific research. In my professional life, I work as the policy director of a scientific society. So the issue of advancing knowledge to improve human well-being is an important one for me. This workshop at the National Academies comes at a critical time for women of reproductive age, when agency in our reproductive choices and the issues of reproductive justice and health equity are front and center. Historically, women, people of color, and other minoritized populations were often excluded from clinical research and research more broadly. This has been especially true of pregnant and lactating people. When a person decides to have a baby, they should also have access to information that can help them make well-informed medical decisions. Like other Americans who are not pregnant or lactating, they too should benefit from knowledge gleaned from clinical research studies. Thank you.
Thanks, Sarah. I'll now turn it over to David to provide the OB-GYN perspective as a follow-on to the patient perspective. Thanks.
Thanks. As a practicing OB-GYN, this uncertainty hits us every single day as we're having shared decision-making conversations with patients. We have to deal with the consequences and the uncertainty as we talk about risks and benefits, and sometimes we can't even do that because we don't know what the risks and benefits are. So it's really hard to have those conversations. There's gaps in nearly every disease state and everything that we're going to see. Patients will come in their first trimester, and whether it's another provider who has told them to stop a medication, whether it's one of the various number of family members or internet sources that they rely on, there's a lot of information out there that really is not based on anything. And that's where the data are so important that we come to generate. And there is some hope. I'm generally an optimistic person, and Preglac has actually done some things. You know, with the Cuddle study for the Pediatric Trials Network, we're getting data on lactation and on relative infant dosing of commonly used medications. The Imprint Hub and the Centers for Excellence in Therapeutics are really making some interdisciplinary strides. I do want to double down a little bit on something that Maggie had said in her talk about there is no such thing as no exposure. People come into pregnancy with complications that need therapy, and there's exposure of the disease itself or of the obstetric condition itself. And there's risks associated with all of those things that have to go into the equation. It's not just a matter of, well, I don't want to take this antidepressant because there's been a study that showed that there might be some issue with it. It's that the problem is that SSRIs have been pretty well studied, and we know that they're not associated with things like obstetric complications. There's small but inconsistent risk of things with birth defects, particularly with things like paroxetine. It has been linked to transient newborn issues, but long-term neurodevelopmental outcomes are okay. But we know that untreated depression in and of itself is problematic. It has been associated with pregnancy complications. It has been associated with increased risk and severity of postpartum depression, the ability of a new mother to bond with her infant, to take care of herself and her newborn baby. And it has been linked to long-term neurodevelopmental outcomes and mental health outcomes in the child. So all of these things have to go into these conversations. There is no lack of exposure. The Lifeline for Mothers program has all sorts of really great materials out there to help people talk about things like mental health in pregnancy when it comes to these decisions. Ideally, when someone comes into the office, you'd be able to do a really good exercise in individualized therapy and counseling. But we don't have those data to really inform dose and choice and things like that. And so most clinicians who haven't drank the Kool-Aid like everybody in this room has, go with a start low and go slow philosophy. And then we lead to undertreatment of a lot of these diseases. When patients come in, a lot of times they will ask about what are the long-term implications? You know, what if I take this medication? What's going to happen? Is my child going to pass kindergarten? You know, what are the long-term implications? And that's why it's so important that we continue to fund really well phenotyped cohorts and not only follow the women's health beyond pregnancy, but also follow these kids and figure out what is happening with all of these kids. You know, we talk a lot about pregnancy changes, but the immediate postpartum time frame is a really orphaned area of what happens in, you know, the minute the baby comes out, there's a lot of changes that happen all of a sudden. And what do we do with the medications in that time period? We talk a lot about lactation transfer, but what happens to the maternal issues with those drugs? Really, another thing, we know that a lot of women pregnant individuals take medications during pregnancy. They also take a lot of them. And so it's not just understanding what the impact of one drug is during pregnancy on the health of the pregnant individual and the developing baby, but it's also polypharmacy. You know, there was a French study that showed that the average number of prescription medications taken during pregnancy was 13. In our new mom-to-be study, even if you get rid of prenatal vitamins and iron, about 1 in 7 folks qualified as polypharmacy with more than 4 prescription medications. So we not only need data on individual drugs in pregnancy and lactation and the postpartum timeframe, but we also need to know about what the impact of the drugs on each other are. And so there's a lot of information that definitely needs to be generated, because we can't have these conversations with patients about risks and benefits because there's so much unknown out there. And then we're asking the individuals who then oftentimes will say, well, what would you do? And it's really hard as a provider, because my space of where I'm at is very different than my patient's space and where they are at that particular time in their life. And so I think we really desperately need these data, and there's hope. I think we're getting some data, and I see a lot of momentum. And I think that practitioners will be really happy when we get all of this.
Thanks, David. Thanks, David. Tom, I'll turn it over to you now. Thanks.
Good morning, and thank you for the invitation to come speak to you. The subject that I was given was comparison of pharmacokinetics in pregnant and in breastfeeding mothers, and I can tell you there's very little comparison there. And secondly, I can tell you we don't know a great deal about it. That's the unfortunate fact of the whole subject here. In the pregnant mom, you've got to me, as a pharmacologist, I think about compartments. You've got the placenta as a compartment. And in the breastfeeding mother, you've got the alveolar apparatus in the breast. That is another compartment. It's distinctly different. And so when you're using drugs in these two different sets of individuals, you've got to always be concerned about how does it transfer through one compartment into the other compartment, and that changes with time. It changes from the first month of pregnancy through the 9th month of pregnancy. It changes from the first few hours postpartum to the very last day that they breastfeed. These kinetics all change and are in flux. And so it's really important that we can do some studies in these moms, because rodent models, and I'm here to tell you, rodent models are worthless, absolutely worthless. Every single study done in a lactating rodent model shows a 1-to-1 milk plasma ratio, and most of those same studies done in humans show 1/10 of that. So much so that I do not even publish anymore rodent milk plasma ratios. They're hysterical, and it intensifies the risk in the subjects and in patients and in the physicians. So I don't even publish those data anymore. So I think the clinical trial situation is poor in the lactation field. I got a call last year from a pharmaceutical firm who said, we're trying to find someone to do a clinical trial with this drug, but no one seems to want to do it. They say it's impossible to do a lactation study. It's highly risky. We just are scared to death. We just don't know what to do about it. And so I said, well, this is not entirely correct, and this is how we do these all the time. And so there's a lot of misconceptions about these trials in pregnant and in breastfeeding moms. And you have to understand the pharmacology. You have to look at the drugs that are being studied. And you have to look at the importance of knowing this knowledge. What Dr. Haas just said, that it's terribly important that moms receive treatment. They have to be treated for their depression, for their syndromes, whatever it is. They need treatment, and therefore we need to know whether these drugs can be used when they're pregnant or when they're breastfeeding. And that's what I encounter every single day. Moms call in, they're being treated for extreme hypertension. Which one of these medications can they use? They're being treated for cancer. Which kind of anti-cancer drugs can they be used? They need treatment, and we need to know that, and we need to know what those risks are when they're being used in pregnancy and in breastfeeding. So it's terribly important that we understand that. And We do understand some of the kinetics, and we understand some of the techniques that we can use in clinical trials to moderate the risk. Some trials, you can take the baby off the breast for a few hours to a day and a half if moms have pumped milk and can feed their babies their own milk. And then there are other techniques and situations you can use in pregnant moms to reduce the risk. Pick the right month to do it in, for one thing, and look at the kinetics of the drug and what its effect may be on the placenta and on the delivery. And his last comment I thought was quite prescient when he said that the polypharmacy in pregnancy is common. I routinely get a call of 10 to 15 drugs mothers are taking while they're pregnant, and then they want to breastfeed. It's every day we get a call like that. So it's an enormously important area. Both these are important areas, and we need to know, and we need to have techniques, and we need federal support for these studies. And I think also we probably need some sort of risk reduction so that we as scientists are not sued out of existence because of some untoward effect that might occur from some of these studies. To be realistic, that's why we don't do these studies, is because of the risk of suits. Some years ago, I was asked to talk to the Food and Drug Administration about including information in the package inserts. And that was a wonderful issue, and it was terribly important because nothing was being included in the package inserts about various trials. And so I thought it was wonderful, and we got that, and it worked well, with one exception. There's no studies out there to put into the... And so even today, you can look for lactation studies in package inserts, and you won't find much. Thank you very much.
Thank you, Tom. I'll turn it over to Ajoke now.
Yeah, thank you. So I guess many of the key challenges have been highlighted by the previous speakers, and a lot of focus has been placed on what has not happened to date, but I want to speak to both the challenges but also to the enormous progress that has been made over the past decade or so, maybe the past 15 years. So clearly, we need to generate data showing the individual as well as the societal upside of including pregnant women in clinical research. And most importantly, disease burden as well as safety data. But to note that this is embedded in a much broader context. There's been research on the so-called gender data gap in visible women, so that pertains both to gender but also to other, to use the word vulnerable populations at a global level. There's a data gap across the globe, and I speak to some specific examples on that later on in the panel discussion. But clearly visible in how the recent COVID-19 pandemic played out, and access to both vaccines as well as drugs for pregnant women internationally. So pandemics have been a turning point for access to drugs as well as vaccines. And to use a quote from Louis Pasteur, chance favors the prepared mind. We've got a wealth of experience now, both from a scientific perspective. We've got 2 vaccines in clinical development, GBS as well as RSV vaccine. So the science has, to a certain degree, been solved with regard to how do we do that, clinical research, clinical development in pregnancy. From a regulatory perspective, the FDA has taken a pioneering role, I have to say globally, because countries everywhere look to guidance and policy development in the US. And that's not just to say low resource countries, it's also countries like Israel and the UK, who have developed comprehensive systems to link maternal surveillance systems, pregnancy obstetric surveillance systems, as well as vaccine and drug research to enable inclusion of pregnant women. And we've got advocates and champions, many of them attending here today, who've diligently worked on this, who are members of policy recommending committees, and who basically take, I would say, a feminist approach to science. We've got obstetricians and gynecologists with the scientific knowledge and experience that enables them to get to a point where we develop permissive guidance, for example, for access to COVID-19 vaccine in the US. I think the key point here is perhaps still too little too late. So we should focus on the tools that enable us to be ready and also to mainstream what has been achieved to date by pioneering stakeholders and organizations. And needless to say, to mention Pfizer, GSK, Johnson & Johnson, others who've now taken on the inclusion of pregnant women in their clinical development programs. And obviously, Johnson & Johnson co-leading this workshop here. I think that in itself is a major achievement. So to note some key pillars to that framework, I think we need an end-to-end product development framework for pregnant women, so which starts out with the preclinical animal models, especially in drugs, and then DART studies for vaccines, to enable earliest inclusion as possible of pregnant persons in clinical trials. We should try to take a platform approach to safety data, for example, to allow us to use available safety data from similar drugs, vaccines, or repurposed drugs. So that became very important in the COVID-19 context as well. Very importantly, link pregnancy surveillance, pharmacovigilance, and disease surveillance. So both, again, in support of drug as well as vaccine development, because as was mentioned earlier, the pregnancy background data on pregnancy, adverse pregnancy outcomes, those are all ascertained in maternal surveillance systems, not in drug and vaccine pharmacovigilance or safety monitoring per se. To have harmonized regulatory guidelines and regulatory incentives for manufacturers to include pregnant women. And this may end up needing to be more purposeful than it is right now. I think there's a fine line between, let's say, enforcing inclusion versus actually creating barriers for pharmaceutical companies to embark on clinical research in pregnancy. I think the pediatric investigational plan is one example, so I know there's some effort to do something similar for pregnant women, but I think that warrants a discussion because it could also de-incentivize manufacturers, especially those who do not have the resources available that large pharmaceutical companies have. And we should be in a position where any manufacturer includes pregnant women per default. Standardized protocols and frameworks make a huge difference across different companies, platforms, but also countries. And manufacturers pursue approval and recommendation across very different geographies. So really important to get a harmonized approach in place. And then very happy to see patient representation and advocacy here, because that's another very important factor. We can produce a much basic research and clinical science data as we want if that doesn't get translated into communication and understanding of a risk-benefit or benefit-risk to the people who who need the medication or vaccines, as well as to healthcare providers who recommend. And at this point, I also, of course, need to mention the Gates Foundation. Just looking back at the past 10 years, I can clearly say that we were in a very different position 10 years ago, because at that point, it took a lot of effort to get people invested in clinical research in pregnancy. So I'm now mainly focusing on maternization, as well as to mobilize champions and advocates across different institutions, because it's not just the manufacturer or clinical research scientists, including pregnant women. This needs to be championed and advocated for in policy institutions, regulators, manufacturers, academia, and needless to say, patient advocacy groups. And in all of these different areas, there's been tremendous progress, and I'm happy to speak to specific examples on that. So it's public-private partnerships, it's close partnership and collaboration between maternal health and drug and vaccine development communities and experts. And it's also taking a global approach because there are 180 million pregnancies annually. Each year, 90 million of those occur in low-middle income countries, and those are the women who clearly do not have access to any of the interventions that are already available to pregnant persons in the US and elsewhere.
Thanks, it's okay. Okay, so I have a question for all of you. So being at FDA, we advocate for the inclusion of pregnant and lactating individuals in clinical trials, and we often receive comments or questions related to, well, they don't want to participate. Do pregnant people or lactating people want to participate in clinical trials? So I'm interested in hearing your thoughts on this issue. Please, I know you're all involved in research, so please share your experiences. Thank you. Maybe Sarah, you can talk from the patient perspective. What do you think? Do you think pregnant and lactating individuals would want to participate in clinical trials? Thanks.
I think I would have been open to it. I mean, I don't have a life-threatening condition, and my condition doesn't shorten my life. So it's not. I think it depends probably on the condition you have. But I think I would have definitely been open to it because based on what I discussed with my doctors, the drug that I was taking was in all likelihood very unlikely to be affecting the fetus. There just wasn't research about it. So my doctor couldn't confirm for me that it was safe. My doctor was just pretty sure it was safe. And I'm the kind of person, I specifically chose to be with an OB-GYN practice that was affiliated with a teaching hospital because I like that I'm helping future doctors receive their training. I work for a scientific society because I'm such an advocate for science. I mean, I'm like the biggest cheerleader for science. This is what I have dedicated my career to. So I'm the kind of person who would be very open to enrolling in a clinical trial. I can't say for certain that I would, but I think I would be very open to it. Thanks,
Sarah. David, please talk about your experience conducting clinical trials.
Yeah, I think there's a lot of variability in pregnant individuals' willingness to get into trials. And I think you have to separate them when you talk about medication studies in pregnancy into opportunistic kind of studies where the individual is already going to be given a medication and we just are going to be drawing some extra blood work to get pharmacokinetics and longer term outcomes versus you're either healthy or you have a condition and we're going to give you a drug that you wouldn't have already been getting. And I think there are wonderful champions and cheerleaders like Sarah out there, but there's still a large contingent in my experience of pregnant individuals who still have distrust and are very, very hesitant to join. And so I think we have a lot of work to do in building that trust in the scientific community. And the phrase that Maggie had said, safety, not protecting them from research, but protecting folks through research, I think is really an important message that I would love to see at every commercial break in the 6 o'clock news, because I think that's the only place we're going to get it is if there's more public awareness of the importance of these things and that we're trying to help people in the long run.
Thank you, David. Tom, can you talk about your experience with lactation studies and lactation trials? Thanks.
Well, it's slightly different in lactation because, as Dr. Haas said, the opportunistic type situation. And that it's different for me because I run a center where we get 100 calls a day, and we get 10,000 women come to our website every day. And so we actively recruit people for these trials. If you're taking this drug, please register, and then my staff will contact you about being included in a clinical trial. And it's worked quite well. I'd say about 90% of the women that register their names are more than willing, but they don't always come through with samples. So we added a little credit card reimbursement and that really helped a lot right there. And so we just have almost more than we can handle right now. But because it's very expensive to do these studies, you have to have a staff that knows how to do the mass spectrometry, how to do the pharmacokinetics of the drug, how to collect the samples. So it takes a lot of time and trouble to do this, and it's expensive to do the trial. But having access to the patients is the whole crux to the matter. That's where it's all out. If you have a place where they call for about drugs and pregnancy all the time, then that's a good population for you to try to recruit from. And maybe you can find ways and methods for doing that. With us, it's the primary way where we do most of our drug studies. And we do 5 to 10 of these every year this way. And so we're trying to pump that data out as much as we can because we just have thousands and thousands coming to the website, and it's relatively easy for us to recruit patients in various kinds of clinical trials.
Thanks, Tom. Ajoke, how about your experience with conducting Group B strep vaccine trials? Could you talk about that?
So for GBS, the highest disease burden, severe disease burden is in neonates within the first 72 hours of life. And it's an ascending infection, and there's basically no way to prevent disease through vaccination after post-pregnancy. In the U.S., there's standard of care available by administering intrapartum intravenous antibiotics, but this is not available in most low-middle income countries. So and I think this gets back to participation in trials depending on what disease we're talking about. Is it preventable? Is there something in place already? And is there a fatal outcome? And I just want to mention here the tetanus vaccination example, which is very compelling, whereas over 180 million women of childbearing age have been vaccinated since the 1980s. And there it was really very stark to communities, and they saw, visually how infants died of tetanus, and there was basically no hesitancy in receiving tetanus vaccination. So with a disease like GBS, it gets slightly more complicated, and that again goes back to data and what is the disease. So then you might need to talk about sepsis in general. But I think that when pregnant women are aware, so I think that the experience in general is that pregnant women, if they're aware that there's an available intervention that may prevent severe disease in pregnancy for themselves or their infants, and thereby saving the pregnancy and the infant, that there is a willingness to participate. And it requires a lot of education, both not just of the pregnant women, but also of the healthcare providers and everyone involved, so including midwives, nurses, etc. And just to know that GBS clinical trials were the first in the US that included pregnant women, so clinical research by Novartis at the time. And right now, there is continued clinical development with GBS in phase 2 by at least two companies, so one company in phase 2 and another one in earlier clinical development. So together with RSV, these two vaccines and diseases really pioneer clinical development of vaccines, because they're the first novel vaccines that are solely developed for an indication for use in pregnancy, with full support by FDA regulators as well as by now major pharmaceuticals.
Thank you, Ajoke. I'd like to turn it over now to the Q&A session. So I'll ask Dina at the back of the room to please, are there questions coming in from the virtual audience? We'll start there and then we'll turn over to in-person questions. Thank you.
So we have the first question that came in from our virtual audience says, how can we better link existing surveillance, for example, pregnancy registries, to drug development decisions and resulting policy recommendations?
Maybe just a comment on that. I think that's really one of the most important efforts that are being, I would say, pushed at this point of time. We've got a few examples. I think the US are actually pretty advanced in doing that. And just to note, the V-Safe effort, CDC pregnancy surveillance for a COVID-19 vaccine, which will also, moving forward, be applicable to any other vaccine. The UK is another great example where there's the so-called UK OS system in place, and this is actually started out on the drug side, but then also included vaccines, whereas a nationwide obstetric surveillance system, which is used to routinely conduct surveillance in pregnant women, is linked to clinical trials and clinical research. So the UK came up during COVID with this novel approach to clinical trials called Recovery. And by linking up that clinical trial system with the clinical development system with the pregnancy surveillance system, they were able, as one of the very few countries, to include pregnant women in clinical drug research for COVID-19 disease very early on. So looking to these countries, I think there's also right now a WHO spearheaded, World Health Organization spearheaded effort going on to really bring together stakeholders from different countries and try to figure out what are effective systems that are already in place and that can then be adopted by others.
Thanks, Ajoke. So now we'll take questions from in-person here, and anybody who's in the audience. Please go ahead.
Hi, everyone. Geeta Swami, Duke University. So I wanted to make one comment and just see about this, what I would call probably a myth for this idea that pregnant women won't enroll in studies. And maybe I'll make a comment and see if people have other things to answer. So one of the things it seems is that we always say that pregnant women are fearful, that they're concerned about their fetus, that they will make those decisions first. I like to use data around flu vaccine uptake. We say we only have about 50% of pregnant women that will take flu vaccine. I'd ask you if anyone looks at non-pregnant individuals and what the influenza vaccine uptake is. And it's really not that much different until you look at in-house patients, say in skilled nursing facilities or long-term care facilities and so forth. So at some point, we still have to remember that pregnant and lactating people are people who are pregnant or lactating at the time. And so if we approach them any differently than we would non-pregnant people, we are doing them a disservice and actually making it harder for us. Everything that I see on TV about come join the study, healthy volunteer study, it's always with reimbursement. I hear people say this is not the reality, so we should make this like real world. I'm sorry, but pregnant people are equally busy. They are working. They are questioning the same sort of thing. So we need to start thinking about pregnant people as people just like everyone else who we are considering for enrollment in a study. And then figure out what are the barriers that are specific about their viewpoint as a pregnant or lactating individual. And so I think if we start moving back to that, we'll get to a better place where we can bust some of these myths about why it might be hard.
Thanks for those comments, Geeta. Did you have a question as well? Yeah, please go ahead.
I guess I can follow on a similar type of comment anyway. So my name is Lod Sharon. I'm at the National Cancer Institute. I help sponsor clinical trials that we conduct in our networks nationally, mostly on immunotherapy. And one of the lowest pieces of, lowest hanging fruits, I guess, that we can get to with regard to clinical trials or inclusion of patients who are pregnant on clinical trials is the reality that people are people. Pregnant people are also people. Some people get pregnant while they're on clinical trials. Some people actually enroll in a clinical trial and then, after they enroll in a clinical trial, become pregnant. That is an area that, as drug developers, is, frankly, something of an opportunity to learn more for that future patient. And what we have done thus far, I feel, is that we've ignored this lowest hanging of the fruit. The regulations that we have, and I put some of the blame on the NIH, but we're basically following, the work that we get from the FDA, from OHRP, from other institutions that essentially regulate us as well, essentially treat pregnancy more or less as a scarlet letter. Once the patient becomes pregnant, they're kicked off the trial. It's one of the 5 or so severe reasons why somebody actually might be kicked off the trial, including things as awful as severe noncompliance and things that people maybe have no control over, obviously unacceptable toxicity and et cetera. But pregnancy is treated more or less the same. And what's unfortunate, at least from my perspective, is that it's very difficult. It's like pulling teeth at that point to try to get more information from some individuals who are essentially summarily dismissed from trials as a result of pregnancy. One might say that we advise people to use 2 methods of birth control. And so maybe one could say, okay, well, this individual was non-compliant with, such and such regulation. But we don't do that, by the way, to the men who get their partners pregnant, right? We only do it to the women who become pregnant on trial. And one of the things, at least, since you mentioned COVID-19, that at least I found very interesting, and I also ran a COVID-19 trial for the NCI for cancer patients. There were 13 women who became pregnant on the Moderna COVID-19 clinical trial. In other words, in December 2020, when the ODAC meeting occurred for the Moderna mRNA 1273 drug or vaccine, there was actually data that was presented publicly about pregnancy, about those 13 women who became pregnant on the trial. That said, of course, it was more or less ignored, I'd actually argue, that 13 of those individuals, I think, if I'm not mistaken, 6 were actually on the vaccine arm, 7 were on the placebo arm. There was 1 miscarriage. It happened to occur on the placebo arm. But that said, that's been largely ignored, and I think that that's something that perhaps is the easiest thing that one might be able to do from an FDA and regulatory perspective, is actually make it easier to collect data, to encourage data collection, and even potentially to include on the label information from patients that become pregnant on clinical trials under IND in the United States.
Great, thanks for your comments. Yes. We are trying to collect that data and FDA advocating for that, so thank you so much. Unfortunately, we're at the end of our time, so thank you very much for... Sorry, we're at the end of our time, and thank you to all the panelists for all your thoughtful comments, and thank you to the audience for your questions and comments. So it's time for a coffee break. All of our panelists will be here throughout the rest of the day, so feel free to go up to them and ask them your questions that you weren't able to ask during the session. Thank you so much.